Their hearts stopped, the monitors flatlined, and in that silence they saw something. Not darkness, not nothing. Something on the other side, real enough to remember, specific enough to document. A researcher spent 5 years inside an intensive care unit recording exactly what cardiac arrest survivors reported when they came back. Not speculation, not comfort. A pattern, the same pattern, repeated across hundreds of patients correlated against clinical timelines, published in over 500 pages of peer-reviewed research. What did they see on the other side? Before this is over, you'll know exactly what that research documented and why the last of these findings is the one nobody prepares you for. There were 4 things, 4 patterns found in cardiac arrest patients whose hearts had stopped and then restarted, 4 things that kept appearing no matter who the patient was, no matter how long they were gone. And the 4th one changes everything we think we know. Her name is Penny Sartori, and before you dismiss what she found, you should know who she is. She wasn't a philosopher. She wasn't a mystic sitting in a quiet room waiting for visions. She was an intensive care nurse, someone who spent her working life inside the most controlled, most monitored, most clinically precise environment in all of medicine, the ICU, a place where every vital sign is tracked in real time, where the exact second a heart stops is recorded, where the exact second it starts again is also recorded, where nothing is left to memory or interpretation, because in an ICU, the machines do not forget. She worked in that environment for years before a question began to follow her home at night. The patients who came back, some of them, were saying things they shouldn't have been able to say, things they couldn't have seen or heard or known. And yet they knew. She started writing it down, not as a nurse collecting anecdotes, as a researcher building a case. In 2005, she completed her PhD at the University of Wales, a 5-year prospective clinical study focused exclusively on cardiac arrest survivors in the ICU. Let that settle for a moment. 5 years, not a survey, not a weekend experiment. 5 years of structured interviews, medical file access, clinical timelines cross-referenced against patient accounts, all inside a live intensive care environment. The study wasn't a memoir. It wasn't a collection of moving stories chosen because they sounded beautiful. It was a rigorous scientific investigation, structured, published, peer-reviewed, and eventually expanded into a book of over 500 pages. The title, Near-Death Experiences of Hospitalized Intensive Care Patients. Not a title you stumble across in an airport bookstore. A title that tells you exactly what it is, and what it is evidence. Here is why the setting matters, why Penny chose the ICU specifically instead of any other environment where people sometimes report unusual experiences. When someone's heart stops in an ICU, you don't just know it happened. You know the exact time it happened. You know how long the resuscitation took. You know which staff members were in the room, what they said, what procedures they performed, in what order. Everything is logged. Every action is time-stamped. The machines are running constantly. The notes are written in real time. So when a patient wakes up and says they saw something while they were gone, you can actually check. You can compare what they described to what was documented. You can ask, does the timeline match? You can ask, were those staff members actually in the room at that moment? You can ask, could this person have known this any other way? Most studies of near-death experiences rely on memory and self-report alone, which makes them easy to question, easy to dismiss. Penny's study had something most didn't: a clinical baseline to measure against, a record of what actually happened written down while it was happening, against which you could hold the patient's account. And what she found when she started measuring was that the accounts matched. Not vaguely, not approximately, with a precision that should not have been possible. Patients described conversations between staff members, conversations they had no way of hearing from a state of cardiac arrest. They described the positions of equipment, the sequence of procedures, the specific words spoken in specific moments. And when Penny checked the records, it was there. All of it, documented, time-stamped. That was when the question changed. It was no longer just, did something happen to these patients? It became, what exactly happened to them? And that is the question that drove the next 5 years of her life. She didn't stop at collecting accounts. She went further. She compared cardiac arrest survivors who reported a near-death experience against those who didn't, looking not just for the presence of an experience, but for the patterns inside the experience, looking for what was consistent, what appeared again and again, regardless of the patient's age, background, religion, or how long their heart had been stopped. What she found were 4 things. 4 things that showed up with a consistency that could not be written off as coincidence. She named them, she mapped them, she published them, and the first one is the one that changes how you think about what a body is capable of. The first pattern was this: they left their bodies. Not metaphorically, not in some vague spiritual sense that could be explained away as a dream or a hallucination produced by a brain under stress. They left their bodies in a way that was specific, observable, and verifiable because they came back with information they should not have had. Penny called it out-of-body perception, and what it looked like in the accounts she collected was remarkably consistent. The patient's heart stops. The team moves in. Compressions begin. Medications are pushed. Voices call out readings and instructions. The room becomes exactly what an ICU room becomes in those moments: organized, urgent, precise. And somewhere inside all of that, the patient was watching from above. That is the part that keeps appearing in the accounts, not from inside the body, not from eye level, from above, as if they had floated to a point near the ceiling and were looking down at the scene below them, at the team working, at their own body on the table, at the equipment surrounding them, the monitors, the hands moving across their chest. They saw themselves being resuscitated. Now think about what that actually means, not philosophically, but clinically. If you are in cardiac arrest, your eyes are closed. You are unresponsive. Your brain is not receiving the blood flow it needs to process visual information. There is no physiological mechanism by which you should be able to observe anything happening in that room. And yet these patients came back describing exactly that: the room, the people, the procedures, from a perspective that was not the perspective of someone lying flat on a table. One patient described the exact position of a piece of equipment that had been moved during the procedure, a position they could not have seen from the bed even if they had been conscious. It matched the medical record exactly. Another described a specific exchange between 2 nurses, words spoken quietly, not directed at the patient, during a moment when the patient had no measurable brain activity. When Penny cross-referenced the documentation, the exchange had been noted in the nursing record. The timing aligned. The words were close enough that coincidence stopped being a reasonable explanation. These were not patients remembering something from before they lost consciousness. The clinical timelines ruled that out. These were accounts of things that happened after the flatline, during the window when, by every available medical measure, there was nothing left to perceive with. And yet they perceived. Penny was careful about what she concluded from this. She did not claim it proved the soul leaves the body. She did not reach for that word, proof, at any point in her study. What she said was simpler and in some ways more unsettling. The accounts are accurate. The details match. And we currently have no scientific framework that explains how. That is not a mystical claim. That is a research problem. One that peer reviewers at the University of Wales accepted as a legitimate doctoral contribution in 2005. The ICU is not a place where people guess correctly about the position of equipment they couldn't see. It is not a place where patients accurately report quiet conversations that occurred while their brain was without oxygen. Coincidence does not produce that kind of specificity across hundreds of separate accounts collected over 5 years. Something was happening in those rooms during cardiac arrest, something that left these patients with accurate, verifiable information about events that occurred while their hearts were not beating. What that something is, Penny didn't say. She just documented it carefully, precisely, the way an ICU nurse documents everything. Without embellishment, without interpretation, without asking the doctor to say more than it actually says. And then she turned the page. Because out-of-body perception was only the first pattern. The second one wasn't about what they saw. It was about what they stopped feeling. And for many of the patients who came back, that was the part they couldn't stop talking about. What they stopped feeling was pain. That sounds simple. It isn't. Think about what is happening to a body during cardiac arrest resuscitation. Compressions, real, forceful, rhythmic compressions delivered to the chest, hard enough to circulate blood through a stopped heart. Compressions hard enough to fracture ribs, which they sometimes do. Electrical shocks if a defibrillator is used. Needles, tubes. The full weight of a medical team's intervention concentrated on one body, with no time to be gentle, because gentle doesn't restart a heart. These patients were not sleeping through something mild. They were at the center of a controlled emergency. And yet, not one of them reported pain. Penny called this second pattern non-physical awareness, and the name matters because it points at something precise. It wasn't that the patients were unconscious and therefore didn't register what was happening. Unconsciousness doesn't explain what came before it. The out-of-body perception, the accurate descriptions of the room, the conversations they shouldn't have heard. These patients were, by their own accounts, present, aware, watching. They simply were not in the body that was being worked on. That's what the accounts describe again and again in language that is different across every patient, but converges on the same thing. A sense of floating, a sense of being above the scene rather than inside it, a feeling of weightlessness that one patient described as the first time in years that her body hadn't hurt. She had chronic pain, documented in her medical file, going back more than a decade, conditions that had followed her every day for years. And in that moment, above the table, above the hands working on her chest, it was gone. She said she noticed its absence the way you notice when a noise you've lived with finally stops. Sudden, clean, unmistakable. That detail stayed with Penny. Because it wasn't unique to that patient, the language changed across accounts, floating, hovering, detached, free. But the core report was consistent across every patient who had experienced the near-death phenomenon. They were present enough to observe. They were aware enough to later recall specific details that matched the record. And they felt none of what was being done to their body. No pain, no fear of pain, no physical sensation at all. What they felt instead was a kind of neutrality, a calm that some of them struggled to put words to when they came back. Not because it was overwhelming, but because it was unlike anything in ordinary life they could compare it to. Not the calm of sedation, not the numb detachment of shock. Something quieter than both, something that a few patients, independently of one another, described as the most peaceful they had ever been. And here is the part that Penny noted carefully in her research, the part that made this more than a collection of comforting stories. The patients who reported this non-physical awareness were the same patients whose accounts matched the clinical record. The ones who described the room accurately, the ones who named the staff, recalled the conversations, placed the equipment correctly. They weren't reporting peace from inside a fog or a dream state. They were reporting it from a position of apparent clarity, the same clarity that produced verifiable details about the world they had left behind. That matters. It means the non-physical awareness wasn't a retreat from the experience. It wasn't the mind shutting down and producing comfort as a final act. It was a different mode of being inside the experience, present, aware, accurate, and completely without pain. Penny documented it the way she documented everything else, without reaching for conclusions that the data didn't support, without asking it to mean more than it said. She noted what the patients reported, what the charts confirmed, and left the gap between them sitting in the published record where anyone could look at it and ask their own questions. Then she moved to the third pattern, and the third one is the one that most people, when they hear it, quietly recognize. Not from research, not from medicine, from something much closer to home and much harder to talk about out loud. The third pattern was peace. Not the peace you manufacture when you're trying to stay calm, not the peace that comes from being told everything is going to be fine. Something else entirely, something that arrived without being summoned and stayed without needing to be maintained. Penny called it emotional neutrality, but the patients called it something simpler. They called it the absence of fear. Think about what was happening around them at that moment, the monitors alarming, the team calling out instructions, the compressions, the defibrillator charging, the organized, controlled, relentless urgency of people working against a clock to bring a body back. An ICU resuscitation is not a quiet scene. It is not a peaceful scene. It is, by any ordinary measure, exactly the kind of scene that would produce fear, the raw, physical kind that moves through the body before the mind even names it. And yet, they felt none of it. What they reported again and again was a calm observation state. They were watching what was happening. They understood what it was. They could see the chaos, the urgency, the seriousness of what was unfolding below them. and they felt emotionally distant from all of it. Not numb, not dissociated in the way trauma sometimes produces dissociation, but genuinely, quietly, thoroughly. Okay. One patient said it this way: she had been terrified of dying her entire adult life. It was the fear that lived underneath everything else, the one she never quite named out loud, but always felt moving under the surface of ordinary days. And then her heart stopped, and the team moved in, and she floated above the scene and watched, and she said the fear was simply gone, not suppressed, not managed, not traded for something else, gone, as if it had never been there at all. That account is in the published research, not a story shared for comfort at a memorial service, a documented patient report, cross-referenced against clinical records confirming the cardiac arrest, the resuscitation, the timeline, the staff present in the room. A person who had carried the fear of dying all her adult life, and at the moment of it felt none of it. Penny noted this pattern carefully because it raised a question she didn't try to answer in the study, a question that sits precisely at the edge of what medicine can measure and what it cannot. If the experience of the transition for those who reported it was characterized not by terror, but by peace, what does that mean for the fear we carry toward it? The fear that shapes decisions, that postpones conversations, that keeps things unsaid for years because we can't bring ourselves to sit with what the conversation would mean. The fear that follows people into their 50s and 60s, not always named, not always visible, but present. Underneath, if the data is showing repeatedly, consistently, that the transition itself was not what we imagine it to be. What do we do with that? Penny didn't say. She wasn't there to comfort anyone. She was there to document what the patients reported and let the findings stand on their own. But the findings standing on their own say this: the emotional experience of cardiac arrest for the patients who came back with memories of it was consistently, across years and hundreds of accounts, peaceful, calm, without fear. Not one of them described what most of us are quietly afraid of. And that is the question that doesn't leave once you've heard it. Not a philosophical question, not a religious one, a pattern question. The kind that keeps a researcher returning to the data, not because the answer is frightening, but because it might not be frightening at all. And that changes something too. There was one pattern left, the fourth one, and unlike the others, the floating, the absence of pain, the calm, the fourth pattern doesn't fit neatly into any category we have. It isn't about where they went or what they felt or what they stopped fearing. It's about what happened to time itself. And the patients who tried to describe it, almost all of them said the same thing first: I don't have words for this. Time for these patients stopped behaving like time. That is the simplest way to say it, and it is also the thing that is hardest to fit inside a clinical framework, because time in an ICU is the one thing that is never in question. Everything is time-stamped. Every intervention is logged to the minute, sometimes to the second. The medical record is, at its core, a document about sequence. This happened, then this, then this. The ICU runs on time the way a clock runs on time. Precisely, continuously, without exception. And yet the patients came back describing a relationship with time that bore no resemblance to any of that. Penny called it distorted time perception. And what the accounts described across patients who had no knowledge of each other's experiences clustered around a few consistent phrases. Time slowed down. There was no time. Time wasn't moving in a line. Some said it felt as if each moment had expanded, as if a second contained more than a second should. Others said time seemed to have dissolved entirely, leaving something behind that they couldn't name but could feel. A kind of eternal present, they sometimes called it, where past and future both fell away, and there was only now, vast and still and without edges. These are not the words of people describing a dream. Dreams have their own strange relationship with time. They compress, they skip, they jump. What the patients described was different. It wasn't compressed or disjointed, it was expanded, spacious, as if time itself had become something you could be inside of, rather than something moving you along. One patient, a retired engineer, someone whose professional life had been organized around precision, sequence, measurement, said that when he came back, the thing that stayed with him longest wasn't what he saw or where he felt himself to be. It was the time. He said it felt like he had been gone for hours. The clinical record showed his heart had stopped for less than 4 minutes. 4 minutes. He spent years afterward trying to reconcile those two things, the 4 minutes the machines recorded and the hours he remembered living through. He didn't resolve it. He eventually stopped trying to resolve it and simply carried it as a question. Penny carried it too, because here is where the fourth pattern becomes more than just unusual. Here is where it starts to push against something fundamental about what we think consciousness is and where we think it lives. The standard model, the model that medicine has operated on for a long time, the model most of us carry without examining it, is that consciousness is produced by the brain. That it is, in essence, a function of neural activity. When the brain has blood and oxygen, consciousness exists. When it doesn't, it doesn't. That is the model. But if consciousness is purely a function of the brain, and the brain during cardiac arrest is not receiving adequate blood or oxygen, then what is producing the experience these patients are describing? What is generating the out-of-body perception, the calm, the absence of pain? And now, the strange, expanded, edgeless relationship with time, and why does the distortion go in that particular direction? Not compressed, not chaotic, but spacious. A brain shutting down under oxygen deprivation does not, by any known mechanism, produce a sense of time expanding. It does not generate accurate visual information about the room from above. It does not create a calm so complete that it erases lifelong fear. These are not the signatures of a system failing. They are the signatures of something else entirely. Penny did not say what that something else was. She never did. Not in the study, not in the book. What she said was that the findings challenge the existing model, that the existing model does not adequately account for what the data shows, and that dismissing what the patients reported because it doesn't fit the framework we have is not science. It is just comfort. The comfort of not having to change the model, and Penny was done with comfort by the time she finished year 5. What Penny published was not a claim. She was careful about that, almost deliberate in how little she claimed given what she had found. 5 years of data, hundreds of patients, accounts that matched clinical records with a specificity that ruled out coincidence, 4 patterns, consistent and reproducible, appearing across people of different ages, backgrounds, beliefs, and levels of fear. And at the end of it, what she put into the published record was not a declaration. It was a challenge to the model. She said this: "We believe consciousness ends when the brain stops functioning. We have built our medical understanding of the mind on that belief. And this data, her data, collected inside the most controlled clinical environment available, suggests that belief may be incomplete. Not wrong, necessarily. Incomplete. That is a precise distinction, and it matters. Penny wasn't standing at the edge of 5 years of research and announcing that she had solved the mystery of what happens after we leave. She was doing something more rigorous than that. She was pointing at a gap between what the model predicts and what the data shows, and saying, as a scientist, we need to look at this. The gap is this. If consciousness is produced entirely by the brain and the brain is clinically non-functional during cardiac arrest, then there should be no experience. Nothing. The lights go out and that is all. That is what the model predicts. But that is not what the data shows. The data shows something happening during the window when, by every available measure, nothing should be happening. Something aware, something that perceives, something that later returns with accurate information about the physical world it left behind, information that can be checked, verified, confirmed against documentation written in real time by people who had no idea what the patient was about to report. Penny sat with that gap for 5 years. She didn't try to fill it with a story. She didn't reach for the language of religion or mysticism to explain what her instruments couldn't. She did something harder. She left the gap open in print in a peer-reviewed document and said, "This is what we found. We don't have a framework that accounts for it, and pretending we do would be a disservice to the patients who reported it, to the nurses and doctors who witnessed it, and to the science we claim to serve. The patients deserve to be taken seriously." That was her conclusion. After 5 years, after hundreds of interviews, after every clinical correlation and peer review and publication, that was the sentence she kept returning to. The patients deserved to be taken seriously and not dismissed, because they had been dismissed for a long time, for longer than most people realize. Patients who came back and tried to describe what they had experienced were gently redirected, told it was the brain under stress, told it was oxygen deprivation producing hallucinations, told it was normal, told in 100 quiet ways that what they remembered was not real. Penny had watched that happen. She had seen it happen to patients she cared for. And she had watched those patients go quiet, not because they were convinced, but because they learned that speaking about it cost them something. The cost of being looked at differently. The cost of having what felt like the most real experience of their life treated as a symptom. She built 5 years of research in part so that would stop, so there would be something to point to. Something documented, something peer-reviewed and published and available to anyone who needed it, patient, family member, clinician, skeptic, anyone who was looking for something solid to hold on to when the question came. And the question always comes, not in hospitals only, it comes in kitchens at night, when something shifts inside you and the noise of the day finally goes quiet. It comes at funerals, when you're standing close to someone you loved and wondering, not philosophically, not academically, but in the quiet animal center of yourself, where they went. It comes to most of us, eventually. And when it does, The data Penny spent 5 years collecting is still there, waiting. Here is what Penny Sartori concluded after 5 years, after everything. Not that there is an afterlife. She never said that. Not that the soul leaves the body and travels somewhere else. She never said that either. What she said was quieter than both of those things, and in some ways more difficult to sit with. She said, "We may not understand what consciousness is. That sounds modest. It isn't." That statement, coming from an ICU nurse who spent 5 years inside a cardiac unit documenting the gap between what the brain model predicts and what cardiac arrest patients reported, that statement is a crack in a very old wall. Because our entire medical understanding of the mind, our entire legal and clinical definition of when a person is present and when they are not, rests on the assumption that we do understand what consciousness is, that it is brain activity, that it begins and ends with the organ that produces it. And what Penny's data keeps returning to, pattern by pattern, patient by patient, account by verified account, is this. Maybe not. Maybe consciousness is not produced by the brain the way a lamp produces light, something that simply stops when the power is cut. Maybe it is something the brain interacts with, something that existed before the interaction and continues after it ends. Maybe the four things those patients described, the floating, the absence of pain, the peace, the strange expansion of time until time itself disappeared, are not hallucinations produced by a system in crisis. Maybe they are glimpses of what remains when the system steps back. Penny didn't claim that. But she did not claim it either. She left the gap open, precisely because the data demands it stay open. She was not in the business of settling questions that the evidence hadn't settled. She was in the business of making sure those questions couldn't be quietly buried, not by dismissal, not by discomfort, not by the institutional pressure to keep the model intact, because changing it is inconvenient. And in leaving the gap open, she did something that 500 pages of peer-reviewed research rarely does. She gave permission. Permission to take the question seriously. Permission to not dismiss what the patients reported. Permission maybe to sit with the possibility that what we most fear about the end of a life is based on an incomplete understanding of what life and consciousness actually is. If you've made it this far with me, subscribe to the channel. New stories like this one every week. Because here is what stays with you after you've spent time with Penny's research. It isn't the clinical precision, though the clinical precision is real. It isn't the four patterns, though those are remarkable in their consistency. It is something quieter than all of that. It is the patients, the ones who came back and tried to describe something that language wasn't built for. The retired engineer counting 4 minutes against hours of lived experience. The woman whose lifelong fear simply vanished in the space above the table where her body was being worked on. The patients who heard conversations they shouldn't have been able to hear, saw procedures they couldn't have seen from where they lay, and came back knowing things the medical record confirmed were true. These were not unusual people. They were not seekers or mystics, or people who had spent their lives looking for something beyond the ordinary. They were ICU patients, people who had been going about their regular lives when their hearts stopped. people who found themselves without preparation or expectation or any chance to brace for it somewhere else entirely, and what they brought back was consistent, not identical, not scripted, but consistent, floating, without pain, without fear, inside a silence so complete it didn't feel like absence, it felt like presence, like something. Like a place that time didn't govern and the body couldn't reach. That is what they saw on the other side. Not darkness, not nothing. Something. Something that 5 years of clinical research, peer-reviewed and published, cannot explain away, and will not pretend to. There is a word Penny uses in her research that doesn't appear in most clinical studies. The word is deserve. The patients deserve to be taken seriously. That is what she wrote at the end of 5 years, at the conclusion of a study that examined hundreds of accounts, correlated them against clinical documentation, published them in a peer-reviewed journal, and expanded them into a book that almost no one outside of nursing and consciousness research has ever held in their hands. The patients deserve to be taken seriously. It is a strange sentence to find at the end of a scientific document. Clinical studies don't usually end with the language of what people deserve. They end with findings, with limitations, with recommendations for further research. They speak in the passive voice and keep their distance from the human beings inside the data. But Penny couldn't keep her distance, not after 5 years, not after sitting with these patients, listening to what they brought back, watching them try to find words for something that language wasn't designed to hold. Not after seeing them go quiet when no one believed them. She had been a nurse long enough to know what it costs a person to be disbelieved about their own experience, and so she wrote it down plainly at the end. They deserve to be taken seriously. What she was really saying underneath that, what the 5 years of data behind it were really saying, is something older and quieter than clinical language can fully carry. She was saying something happened to them, something real, something consistent, something that didn't fit the model, didn't ask permission to not fit the model, and continued not fitting it across hundreds of separate accounts, collected across 5 years in one of the most monitored environments in all of medicine. Something happened to them on the other side, and we don't know what it was, not because no one looked. Someone looked, carefully, rigorously, for 5 years, with a PhD and a clinical database and the full apparatus of peer-reviewed research behind her. She looked as hard as anyone has looked with better tools than most, and at the end of it she said, "We don't know. The model doesn't account for this. We need to sit with that, openly, instead of explaining it away quietly so we can keep the framework intact." There is a kind of courage in that, not the dramatic kind, the quiet kind, the kind that shows up in a published document and stays there, available, waiting for anyone who needs it, waiting for the nurse who carries her own questions home after years at the bedside, waiting for the person who lost someone and finds themselves in a moment when the house is finally still, just wondering, waiting for the one who came back from something and couldn't find the words and was told carefully, gently, that it wasn't real. It was real. The data says it was real. The clinical records say it was real. The consistency across hundreds of patients who never met each other, never compared notes, and arrived at the same 4 things independently. That says it was real. And Penny Sartori PhD, ICU nurse, 5-year researcher, says it was real, carefully, precisely, without overclaiming, in print where it will not disappear. That is what cardiac arrest patients saw on the other side, not what we feared they would see. Not darkness, not the end of something, something that floated above the table and felt no pain, something that watched without fear, something that existed outside the edges of measured time and came back carrying details the machines could confirm, something that came back with them. There's another account waiting here on this channel, a man who crossed the same threshold, and what he found on the other side looked nothing like what Penny's patients described. No peace, no calm, something that unsettled him so completely he stayed silent about it for 17 years. Same crossing, completely different shore. If that story calls to you, it's already here. Subscribe if these accounts have found you at the right time, and if this one stayed with you, leave that in the comments. Someone else who needed to hear it found their way here too.